Hello, everyone. Welcome. We will get started at 2 p.m. sharp. On the East Coast, and good morning to those of you on the West Coast. Welcome to our first HPV vaccination best practice session. We are so grateful you have chosen to spend the next hour learning, and we hope you find this session informative and inspiring. Next slide. I'm Melissa Santiago, HPV Program Manager at the American Cancer Society, and I'm honored to be moderating today's session. Before we get started, I'd like to review just a few housekeeping items. Next slide. Today's webinar provides continuing education for providers, pharmacy, and nursing. We will be sharing the survey link to claim continuing educational credits at the end of the session and in the follow-up email. Next slide. Our session today will be recorded, and the link to view the recording will be shared with all registered attendees. We have an incredible program ahead with our esteemed partners who I will introduce shortly, and I encourage everyone to utilize the Q&A feature to post your questions. We have my ACS colleagues who will be sorting through the questions as they come in. In order to meet those objectives, we have a thoughtful agenda for today's event. Our speakers should not be a stranger and bring a wealth of knowledge and experience to our first best practice session. Next slide. Now it is my distinct honor and privilege to introduce today's distinguished speakers, who are thought leaders, experts, and change agents in the field of HPV. We will first be hearing from Dr. Jessica Young, Clinical Assistant Professor of General Pediatrics and Adolescent Medicine from the University of North Carolina, and Dr. Noel Brewer, Skilling's Distinguished Professor in Public Health, also from the University of North Carolina, and later on from our very own Christina Turpin, Director of the National HPV Vaccination Roundtable. Thank you all for being here with us, and without any further delays, I give the floor to you, Dr. Young.
Thank you so much, Melissa. And good afternoon, everyone. Thank you so much for having me today. And I'm excited to be here with my colleague, Dr. Noel Brewer. And we're here to talk with you about effective HPV vaccine communication, specifically release of the updated announcement approach training. So before we kind of jump into our slides planned for you today, I just want to review a few disclosures. This webinar was coordinated by UNC and the American Cancer Society. The announcement approach training was developed with funding from the National Cancer Institute. And Dr. Brewer does have a few disclosures he'd like to present today. He has been a paid consultant for CDC, Merck, Moderna, Novavax, Sanofi, and the WHO. And I personally do not have any conflicts of interest to report today. So our desired outcome, the reason we're here today is because we want to encourage healthcare systems to lead HPV vaccine communication trainings in their clinics. So to do that, we have a few activities that we've planned for you all today. First, we'll start off by reviewing the announcement approach training, which you might hear me refer to as the AAT. We'll also discuss some AAT updates that we've made over the past year, as well as share some AAT success stories with you all today. And as Melissa mentioned, toward the end, we'll have the opportunity to participate in a question and answer session with you all today. So if you do have questions that come up, as we are talking with you about some of the materials that we have planned, please feel free to put them in the Q&A. We'd be happy to address them for you. So first, we'll start off by just giving some background and an overview of what the announcement approach training, or AAT, is. So what is the AAT? Why are we here today? So the AAT is really a training on how to effectively recommend the HPV vaccine. And the training is for both providers and nursing staff, and we found that it works equally well for both of those audiences. The training total time usually takes about 60 minutes and is done in clinic and led by a person either in that clinic or usually within that healthcare system who also has experience with providing HPV vaccines. We're proud to report that the announcement approach training is a National Cancer Institute designated best practice as well. And as a part of the training, our attendees receive certain materials that can help them along with the training. The facilitators or the person who is kind of delivering this training receives a script that shows them exactly what to say, how to say when presenting this training, along with slides. Within a training, we have demonstration videos, which you'll get a chance to take a look at a little bit later today. And then all of our attendees also receive a flyer that has messages on how to respond to certain concerns that parents or caregivers may bring up as HPV vaccine related concerns. So what are the benefits to the AAT? We're happy to report that we found quite a few. Particularly benefits to clinical staff include the following. We've seen boost in HPV vaccine uptake by 5%. The AAT can really help to simplify discussions around HPV vaccination. And ultimately, what that does for us is allows us to save time in the visit, which allows us to focus on other important health concerns that either we as providers or the parent might have for that visit. It's also been shown to increase patient satisfaction. So studies have shown that patients, families, caregivers, parents, they actually prefer this type of approach when receiving counseling about HPV vaccine. And as I mentioned earlier, this training is equally effective for nurses as well. The CDC and the American Academy of Pediatrics both recommend using presumptive announcements in HPV vaccine counseling, and this is exactly what we teach in the announcement approach training. So I want to pause just for a minute because we have a poll for you all. So you should see that pop up on your screen, hopefully here shortly, but we'd love to know, has your healthcare system or clinic held an AAT workshop? And so I'll just give everybody a minute to answer that poll.
We're a little over 60%, so thank you. Just give it a couple of more seconds. All right, Kayla, I think we can go ahead and close the poll and share the results.
All right, thank you so much, everyone who participated in that poll. I see we do have some attendees who have been a part of the AAT workshop before, so thank you so much for being here today, and we hope that you found that AAT experience very valuable for you and your practice. And we see a lot of people here today who they've not been a part of the AAT workshop, and so we're happy to be here today to share a little with you about what that looks like. And then we'll have some information toward the end. If you are interested in having an AAT workshop in your clinic or healthcare system, we'd love to help you get that set up. Thank you so much for answering that poll. So the AAT, we're happy to report, is used nationally. It's been used in over 2,000 clinical staff in over 20 states. You can see those states represented here by the various green stars on the map. But I'd like to pause here again and ask you all to use the chat feature to let me know if there are states not represented here on this map and where the AAT has been used. So are we missing anyone here? And we'd love to hear if there are other states that are not represented on this map where the AAT has been used. And so again, I ask you to use the chat feature to share with us if there are states that we are missing as a part of this map. Now I'll pause just for couple of seconds to see. So I see someone mentioned using it in Maine, North Dakota. Awesome. Okay, and feel free to continue to put those states in there as we go along. I see Alabama. Thank you. So we thank you for giving us the information, and we will love the opportunity to kind of update this map. I see Georgia as well. Thank you. So that's really helpful to know that the AAT is continuing to expand into other states as well. So thank you so much. And so, as I mentioned earlier, there is high satisfaction with the AAT. I mentioned earlier that parents prefer this type of approach when receiving HPV vaccine counseling. But we also have found that our attendees, our providers and nurses who attend these trainings, are also highly satisfied with this approach. In fact, 100% of attendees stated that they would recommend this training to a colleague, and 93% plan to routinely use this communication strategy in their day-to-day practice. And in the words of one of our attendees who stated, "It's easier for parents, it's easier for us." We'd like to highlight this quote because, again, not only does it come directly from one of our attendees, but we've also found that our data also supports that people are very highly satisfied with this training. And so now that I've kind of given some background on what the AAT is and where it's been used, I'd like to just give you a little bit of an overview of the announcement approach itself and give you a little bit of an overview of what an attendee sees when they attend this type of training. So the announcement approach really involves 3 key steps. Those steps are: 1, make an announcement or announce. The second step is connect and counsel, and that step is used if a parent hesitates or expresses any questions or concerns about the HPV vaccine. And then the third step is try again, and that step is reserved for those parents or caregivers who ultimately decline HPV vaccination at that visit. And so now I'd like to dive a little bit deeper into each of these steps and give you a little bit more insight into what each step involves. So again, that first step is the announce step, and this is the part where we teach our participants how to make that initial strong recommendation using a presumptive announcement. So we encourage our attendees to note the child's age in their announcement, and this really cues the parent or caregiver that what we are about to recommend really follows routine preventive care for that child's age. We also teach our participants how to announce that at this age, they get a vaccine that prevents against 6 HPV cancers. And we know that it's really important to emphasize the disease process because we know that's what parents really care about the most, and that's what resonates with parents the most. And then finally, it's very important that in this announcement, providers or nurses mention that the plan is to vaccinate with the HPV vaccine today. So here is an example of what that announcement might look like. Alex is now 9. So today they'll get a vaccine that prevents 6 HPV cancers. So at this point, if you have a parent, they're excited about the vaccine, they're ready to vaccinate, then you can move on with the rest of the visit and address other important health concerns. However, if you have a parent or caregiver that hesitates or has questions or concerns, you would then move to the second step, which is connect and counsel. So let's first talk about the connect part of this step. So in the connect step, it's very important that we ask the parent for their main concern. So really try to get an understanding of what the parent is worried about when it comes to the HPV vaccine. And additionally, this is a really important step where we can utilize those reflective listening skills. And so to show that we're listening, we repeat the parent's own language to emphasize that we understand what their main concern is. So here's what the connect portion might look like. As the provider, you might say, "What would you say is your main concern?" The parent might respond, "I thought that they wouldn't need any vaccines for a few years." And to show reflective listening, you may say, "I hear you. You didn't expect Alex to be getting vaccines at this visit." So after you've taken time to connect with the patient or the family, now it's time to move to the counseling part of this step. And so in this step is where we teach participants how to address parents' concerns using research-tested messages. If you recall earlier, I mentioned that all of our participants receive a flyer as a part of attending the training, and that flyer supplies them with messages on how to address common concerns that may come up for parents as it relates to HPV vaccination. And then again, in this step, we emphasize the importance of clearly recommend getting the HPV vaccine today, and also explaining to our attendees that it's important to give a reason why it's important to vaccinate today. So here's what that counseling portion may look like. The American Academy of Pediatrics recommends that kids get the HPV vaccine starting at age 9 to prevent 6 cancers. I strongly recommend Alex get it today because the vaccine works better when given younger. So if you have a parent, you've done your presumptive announcement, they had some questions or concerns, and so you move to connect and counsel step, and they still ultimately decline the vaccination for that visit, You would then move to the third and final step, which is the try again step. So for this step, it's very important to verbally say to the parent or caregiver that you will bring up HPV vaccine at the next visit. Again, this allows for another chance to emphasize that the HPV vaccine is important for their child. And importantly, it's very important that we make a note in the chart for this patient, making a note that we recommended the HPV vaccine and the plan is to also try again at a future visit. And this can be a really important step and serves as a reminder and communication tool within a practice to remind us all to make sure we re-recommend the vaccine at that following visit. We know that most parents who initially decline HPV vaccination are willing to get it at a later visit. And so it's really important for us to remind ourselves to go through this approach again at the next visit when we see them for follow-up. So I will now pass it to my colleague, Dr. Noel Brewer, who will take us through some AAT updates and also show us how to put the AAT to use in healthcare systems and clinics. Thank you.
Hi, folks, and thank you so much. Thank you so much, Dr. Young, for getting us going here. So I'll go through what some of the updates have been to the announcement approach training, that's the AAT. So what's new in version 2024 that we're releasing right now? We've modified the steps a little bit. Before connect and counsel used to be separated, they're now a single step, as you just heard in what Dr. Young presented. We had them separated previously because we thought they were important, but it turns out that, I mean, they're certainly important, but it turns out that the two of them link together and the counsel step is inevitably part of the connect step. In addition, we have a try again step to be able to reach the parents who fully refuse. It used to be an implied activity, and now we state it explicitly. We've also have a new emphasis on age 9, and I see a comment here in the chat about age 9. There are some nice resources that the National HPV Vaccination Roundtable provides that you can take a look at. The main thing about why you can recommend at age 9 is that ACID does support starting at age 9. They say it's allowable, and indeed many organizations have emphasized this and are even pushing for it. So the National HPV Vaccination Roundtable says that HPV vaccination starts at age 9. The American Academy of Pediatrics is also supportive of vaccination ages 9 through 12. So that's part of this national push to start HPV vaccination younger. And also the announced step now focuses solely on HPV vaccination at ages 9 or 10, but we have an adjusted version of it for the 11 and 12-year-old age range if that's when you're recommending. There's a new focus on DEI issues, diversity, equity, and inclusion. So the materials highlight HPV's impact on Black, Hispanic, and rural communities, all of which have higher rates of HPV cancers. The announcement is now described for a non-binary patient, a child that does not use binary pronouns. We use names for children that are common in multiple racial and ethnic communities, and then we also include a Black family in the demonstration video. And speaking of the demonstration videos, there are now 2 of them that we had done with professional actors, including the person playing a pediatrician is actually a pediatrician in real life who plays the pediatrician on screen in her part-time, apparently. So I'm going to go through those 2 videos. This first video is for ages 9 to 10 and goes through the announced approach for a family that's relatively easygoing. So the 2 of the steps of the announced approach are going to get used here.
Now that Marcus is 9, it's time to get started on a vaccine to help protect him against 6 HPV cancers. He'll get his first dose today and his second one at his next checkup.
HPV vaccine for a 4th grader? Wow, I wasn't expecting that.
Okay, it sounds like you have some concerns about that. Can you tell me more? What would you say is your main concern about the HPV vaccine?
Isn't he too young? My older daughter didn't start that one until she was 12.
I hear you. It is hard to believe that Marcus is old enough for the HPV vaccine. It probably seems like just yesterday you were doing his booster vaccines to get ready for kindergarten. But 9 is actually a great age to get started.
Really? Why is that?
Well, for one thing, kids have a stronger immune response to the HPV vaccine when they're younger. That may give them better protection against HPV cancers later on. Another advantage to starting now is that Marcus still has plenty of time to get both doses at his regular checkups. That way you don't have to bring him in for extra checkups.
Okay, if you think it's time, we'll go ahead and get started.
Great. So Marcus will get his first HPV vaccine today. At his next checkup, we'll give the second one, and then he'll be all set.
Okay, so that's our first video, and let's go through the second one as well. So the second one is for ages 11 and 12, and now you're going to see two differences. One is there's a bundling approach that sandwiches HPV vaccination between meningitis and Tdap vaccines, and the other is that the mom in this case is a little more skeptical, and so they have to use the full announcement approach in this interaction. Oops, we went right by. Sorry about that, folks. Let's try again.
Now that Sophia is 11, it's time to give her vaccines to protect against meningitis, HPV cancers, and whooping cough. We'll give those at the end of the visit.
Yeah, I know she needs to get some vaccines before school starts, but HPV vaccine? I don't think we need that one.
Okay. It sounds like you're not sure about the HPV vaccine. Would it be okay if we talk more about that?
Yeah, okay.
What would you say is your biggest concern?
I've seen some bad stuff online, like that HPV vaccine can cause infertility and that kind of thing. I just don't want to risk it.
It makes sense that you'd be concerned about those stories. The good news is that researchers have conducted over 100 studies on the safety of HPV vaccine. They've consistently found that it's really safe, just like the other vaccines we give at this age.
Okay, but what about fertility?
Many studies have looked specifically at fertility, including ovarian health. The findings are reassuring. There's no evidence that HPV vaccine causes infertility or any other reproductive health problems. What can cause infertility is cervical cancer, which Sophia would be more likely to get if she's not vaccinated.
Yeah, I don't know. I just don't think the HPV vaccine is right for our family. I would need to talk to her dad before making a decision like that.
I hear you. Today we'll do the Tdap and meningitis vaccines. I'll put a note in her chart and we'll revisit the HPV vaccine at her next checkup after you've had time to talk to her dad about it. I want Sophia to have every opportunity for cancer prevention, so let's keep talking about it.
Okay, that sounds good.
Okay.
Right. So in addition to the videos, we also now have a technology-assisted practice session. Delivers the practice vignettes and the roles for each person is going to have while they're practicing the announcement approach with one another. And it streamlines access to the flyer that Dr. Young shared before. It's a nice flyer that also includes these messages for what to do when specific issues come up about the child being too young or not being sexually active or that it's not for boys. In addition, we have a standardized facilitator orientation now. So in this orientation, we help folks who are going to lead the announcement approach trainings get up to speed. They'll attend an announcement approach training so they can see what it's like. We review evidence behind the training and why it works. And we also help build facilitation skills as well as an understanding of the necessary logistics to pull off a successful training. I'd like to thank the update team here that I led along with input from Drs. Gilkey and Young. And then we had a lot of other support as well, but I especially want to call out Katie Kritikos, who's on the call today, and she was invaluable in helping bring all this together as well as to coordinate this, our participation in this webinar today. So now let's talk about putting the announcement approach training to use. First, we'll have a few people talking about what's great about the announcement approach and then how it's working for them. And then we'll also tell you a bit about how to access the materials, which should help answer one of the questions that came up in the chat. So how do you bring the AAT to your colleagues? Well, to engage a healthcare system, you need to meet with the senior decision makers in quality improvement. That's a key thing to do. You will need to also identify a champion to serve as the AAT facilitator. And you'll also need to find staff who can offer administrative support for scheduling and getting the slides and all that good stuff. In addition, once you actually go from the sort of building organizational support to the actual concreteness of how do you hold an actual individual specific workshop, that person leads it is going to attend a facilitator orientation that UNC hosts. They're free. We'll give you materials like slides and the script and the flyer and other things. And then you're going to have to, of course, plan the logistics, and then hopefully you'll have a great training workshop. So here's one brief comment by a colleague at a healthcare system, a large healthcare system in Texas. It was a huge deal for us, not only for all the education it provides, but it has been a great team building exercise. The research team encouraged us to make sure everyone was given the opportunity to speak up. So our MAs, LVNs, and RNs, as well as our providers, are talking and engaged. And indeed, that's what we hear a lot of, is that this is an opportunity for the entire clinic to come together and have a conversation about HPV vaccination and be clear about what the norms are within the clinics and also how to share the work of recommending HPV vaccination. So now I'm going to turn to another person, Dr. Ken Alexander, who's joined us from Orlando. He's the Chief of Infectious Diseases at Nemours Children's Health. Dr. Alexander.
All right. Well, thank you, Dr. Brewer. It's a great opportunity to speak with everyone. And what I was doing was sharing with my colleagues the announcement approach and really teaching them how to do it. And to begin with, it was fun. We had a good time. People were initially shy as I worked with them, but eventually people warm up. We talk to them, and by the time we're done, we're supporting each other, and there was a lot of laughter and smiles. So in the end, it was really a delightful process. The challenges we had, in part, the announcement process is really counterintuitive to what we often think as providers. As healthcare providers, we tend to think that if we just give people enough information, they're going to make the right decision. And the more we say, well, that shows how much we know, and we build confidence and everything's better. So the announcement process is counterintuitive to that. It's much more specific about what we say, and we don't say too much. And guess what? The data show that it works. So who benefits from this presumptive announcement process? Well, I think families do, because again, we see more families making the right decision to vaccinate. It gives them a straightforward way to go. But I think there's another important part, and that is we as providers benefit, and we benefit in two ways. First of all, you've heard about the idea that the process is shorter, more efficient. Absolutely. But I think an important thing to keep in mind on the announcement process is it builds on the presumption, the confidence that families want to do the right thing. And that gives us confidence that we're all working on the same team, that we're not going to open the lid on an antagonistic process. And so it makes us more willing to bring up the announcement, more willing to advocate for vaccination. And again, it just gives the whole process a more positive tone. And I think this steps past the process of the anxiety that a lot of providers have with what's going to happen if families bring up questions, because the announcement process really, in the presumptive aspect of it, puts us all on the same team. So as you look at this process for your own institution, think about it as a QI process. It's a great project for somebody to do. It's a lot of fun. And having done it with several groups, I can strongly endorse it as a teaching opportunity and as a learning opportunity.
Thank you so much, Dr. Alexander. We have a poll here about asking whether you're interested in hosting an AAT workshop in your healthcare system or clinic, now that you have a bit more information. The initial results show a good mix of people.
We're about 55% almost. I'm going to give it a few more moments.
And I'll go through how to get the materials in just a few minutes.
All right, I think this is a good place to stop the poll and share results.
Well, good. So we have a good cohort of you that are ready to go. So we'll contact you and let you know about these materials. And I'll tell you about that in just a second. About half of you are thinking about it. And so I'm thinking maybe not now. We're kind of busy. And maybe this isn't exactly your role, but certainly you'll have the opportunity to access these materials at a later time if you're interested. Okay, so let's move forward here. This is the question. How can I access the AAT materials? Well, we're going to email you if you expressed interest in the poll that you just answered right there. And there's nothing you need to do. We'll just automatically send that to you. You can press delete on the email, or you can open it and choose to engage. We be happy to interact with you. Also, for whatever reason you missed the poll or you need to contact us at aat@unc.edu. Another question is, do you offer continuing education credits for AAT workshops? We do not offer that credit for the workshops that other people host. When we do it ourselves, we always offer continuing education credits, but you would need to coordinate that yourself. It's not too hard to do. It's pretty straightforward. Most universities and institutions have ways to generate those continuing education credits. I will strongly encourage you to offer medical credits and nursing credits. About 3/4 of the folks who are attending are not providers. They're nursing staff and varying levels of nursing staff. And so it's really important to include all those folks in the continuing education process. To lead an AAT workshop, do I have to attend a facilitator orientation? No, that's the short answer, but the longer answer is we really encourage you to do that. You're going to get a lot of good resources and you'll be a lot better prepared to lead those. And I think you'll just have more fun. You'll also get to know a few other people, including the folks here at UNC. So if you're interested in doing that, you can contact UNC at aat@unc.edu. All right, so we're at the Q&A moment here. I see some chat comments in the chat, and we'll be in touch with you about Stephanie. I see that you would like to participate but didn't get to the materials. You want the access to the materials, and we'll let you know. We'll have a way to find you. Okay, so I'll turn things back over to our ACS colleagues for the Q&A.
Sure. Thank you, Dr. Knoll and Dr. Young and Dr. Alexander for your testimonial and your presentation. We love to see all of the updates, and we love the emphasis on age 9. And I'm sure you're going to have a busy couple of months with all of the trainings that people said they were interested in. So folks, we're moving on to the Q&A portion. So please do keep those questions coming in the Q&A box. We've had some chatter in the chat, so we will address those since we know you don't have access to see what's coming in. But I'd like to take a moment first to address some of the questions that came up during registration before we move on to the audience questions. So UNC team, one of the questions that came up was, if someone's interested in hosting the training, what is the investment and time commitment? Can you talk a little bit about that?
It's going to vary by the organization, but I would say it's around a fixed amount of time of 10 hours to interact with us, get the materials, review them, attend a training, practice, do the scheduling to get all that other stuff going. So this is the facilitator time as well as the admin time. And then for every additional facility that it's held in, it might be maybe an hour and a half of time because you'll have to be there during the training. And then also there's a bit of scheduling and coordinating. So that's a sort of about a fixed 10 hours and then maybe a marginal time of about an hour and a half per workshop. We also encourage you to try at least a couple workshops. If you have 3 clinics, it's best to have one person do all 3 because you do get better at it. The first one you do is going to be okay, but the second one you're going to do is going to be good. And by the third time, it's going to be amazing. So it's really good to have done a little practicing and then get some additional practice under your belt.
Thank you. We also had questions around how do we utilize this training in a team approach? Who should be participating in this training?
Maybe hand that to Dr. Young.
Yeah, so that's a great question. As we mentioned, our training is designed for both providers and nursing staff. And so that is the audience that we gear these specific AAT workshops toward. However, with that being said, as we think about the process involved with scheduling patients and really bringing patients in to get the HPV vaccine, it really does require a whole team approach. And so as a part of the training, we do I recommend and encourage our participants to think about how the entire clinic staff can play a role in HPV vaccination. So even thinking about our front desk receptionists who could potentially be someone to identify the age of the child and put a quick note in the chart that the child is due for HPV vaccination, thinking all the way to the end of the visit, who is going to schedule that child for the next follow-up, who is going to make a note in the chart that the patient is still due for HPV vaccine or that they declined HPV vaccine that particular visit. And so there is an opportunity and role for everyone in the clinic to play a part of improving HPV vaccination within the clinic.
Thank you, Dr. Young. Katie, I think we're ready for our first audience question.
Great, thanks. Okay, I've got a couple in the chat. So, Dr. Brewer, the first question is, does your AAT material represent diverse communities and backgrounds? Is there a way to tailor your materials to those communities? Is there any information around mistrust?
All really important questions. So we have a single set of materials and a single approach that's used across everyone right now. There is some question, for example, do we need to have materials available in Spanish? And we have a colleague, Dr. William Kahlo in Pennsylvania, who's been doing work on that. Currently, we do only offer the materials in English. Are these materials is this approach equally well accepted by various groups, including Black families, Hispanic families, and others? We don't fully have as much data as we would like on that. It appears though, and I think there's also a lot to be said for a concordance between the race ethnicity of the provider and the family. There are a lot of data suggesting that sometimes the visits can go better in those cases, and also the quality of care can even increase. But that said, this is meant to be a one-size-fits-all, given that there are a lot of different communities and people and types of clinics and types of setups for clinic flow. So we try to create something that can be used in any situation. It is possible to adjust it depending on the needs of the clinic.
Great, thanks. Okay, we have another question. You state that the immune response is better if the vaccine is started younger. I've seen the data that supports this, but does the data differentiate the immune response for those starting at 9 and 10 versus 11 and 12?
I don't have the exact answer to that off the top of my head. We also have Dr. Alexander here and Dr. Young. I want to give an accurate answer, not the one that's on the top of my head. So that I think is right. Does anyone have the immediate answer? If not, we can try to get that. And if we have the contact information for the person, we can get that to you. Generally, the immune response is higher at younger ages. However, immune response is not a correlative protection, so we don't know for sure that having a 300-point higher immune response equals more cancer protection. Ken, can you pick that up?
Yeah, I think that's exactly the way to look at it. I think there's two aspects to it. One is that it's a truism that our immune responses are better in younger patients, whether that's substantially different between 11 and 9, as I think probably splitting hairs. I think the other thing to keep in mind is that when you immunize at 9, you've got more years and more opportunities to get vaccine in, and that makes for better immunity.
Right. There's also the data on exposure. You're less likely to be exposed to whatever the various kinds are. There's the strong immune response that we've heard about. And our data is pretty persuasive about younger ages, the Gertig data, but you're right, it's not the 9 versus 11. It's like age 14 and younger-ish versus older. And the protection against cervical precancers is really quite impressively higher.
And can I just add one quick plug? This is a good example of some of the additional information and data that we dig into a little bit more in the facilitator orientations that can help you feel a little bit more comfortable as you're presenting or teaching others how to deliver the AAT. And when you get those types of questions, you'll have that support from that facilitator orientation and that information to help guide those questions too. And we do review data on immune response in younger ages, and the data, as Dr. Brewer and Dr. Alexander already mentioned, it just kind of shows an overall better immune response in a younger age. I haven't seen the difference between 9 to 10 or 11 to 12. I think they mostly look at that less than 12-year-old age group. But it does kind of, again, give you that additional data to help you feel more comfortable and answer those questions as they come up.
Great, thank you. Okay, we've got a two-part question for Dr. Brewer and for Dr. Young. So Dr. Brewer, our participant would love to hear from you on why the audience should care about HPV vaccination at this moment in time, so post-pandemic. And then for you, Dr. Young, what are you seeing in the practice setting in terms of gaps in care for adolescents?
I just put a link in the chat to a video on why to start at age 9. And I just think it's so persuasive. 9 reasons to start at age 9 is terrific. It was developed by the National HPV Vaccination Roundtable, and I think it summarizes it so well. So I'll let you all watch that on your own time. And if we have time here, I don't know if we do, can we do that? Can we actually share that video now? It's cool. It's about a minute long. If we can't, then we can go on to the next part of the question.
I don't know that we can, but we can certainly include it in the wrap-up
Good.
notes that
Yeah.
are sent to the participants. And Dr. Young, what are you seeing in terms of gaps in care with adolescents in your practice?
Yeah, and I want to be mindful that I can interpret that question a lot of different ways. And so if there is something specific that you want me to address, I'm happy to just let me know. But just in general, I think we know that, adolescents are at risk for being lost to follow-up, particularly in those teenage years. And so just going back to the kind of recommendation of HPV vaccine at age 9 is something that I really think about when I think just in general about adolescent care, and that I'm less likely to see those patients throughout their teen years. And so the best chance for me to kind of recommend and counsel against the HPV or for the HPV vaccine is really going to rely heavily on those younger preteen years, because we really miss out on a lot of adolescent care or well visits during those teenage years in general.
Great, thank you. Okay, we've got several more questions. Is there a recommended source of literature or online information to give a hesitant parent to look over while they are deciding on HPV vaccine before their next visit?
We are a little hardcore about this. I don't recommend it. The single biggest impact on HPV vaccine uptake is the recommendation of a provider or a nurse. There's nothing like it. The odds are 10-fold higher if a family receives a recommendation, if they don't, that they will go on to get the vaccine. There's no intervention that's as good as that. And handing off a flyer or whatever, you can do that. It's a bit passive. And honestly, it's just going to take up their time and your time. They might not read it and they'll feel bad about it. And it'll just create this weird friction. Bring them back and just say, hey, let's have a conversation. Make it brief. Just keep doing this briefly, but over time. Now, there was a comment earlier in the chat about being concerned that adolescents often don't come in every year. Sometimes they might come on every other year, every third year. That is true. That is a challenge. That's especially a reason to start at 9. And then if they're coming in, say, 3 years later, you're getting them again at 12, and you have another chance to go. If a family is really in the hell no camp on vaccination, first of all, they're entitled to do that. They really are entitled to say no. It's okay if they say no. We would prefer not. It's against medical advice, but families do have autonomy, as we all know. And your advice over time, kindly, gently, firmly, that will have a really big impact. For people really set on an opinion, it's not going to change. Sometimes it'll change in the course of a clinical visit, but typically it's going to change slowly and over time.
So just keep at it. All right.
Yeah.
Okay, I've got more for you. Is it intended that the facilitators of the AAT training always be a physician?
No. We
No.
have found that that's something we typically recommend because of the power dynamics in offices, typically value the opinion of a physician. That said, there are many nurses, nurse practitioners, PAs, and so on, who are vaccine champions, are incredibly effective and highly respected. The key is to find in your organization who's the person who has that gravitas, who people look to and say, yeah, I respect them and I want to do what they recommend that I do. That's the person to have at the front of the room. Now, it often can't be a super senior person. They're just so busy and they may not be able to do all this work. But someone who has 5 or 10 years of experience, great. You don't want to have this be handed to a person who has no experience in vaccination or is someone who has relatively little experience with your clinic. That's not the ideal situation. It's best if it's someone from your system and ideally even within your clinic. There's one point earlier that I wanted to pick up on, which is someone had asked about mistrust among some communities. And I answered half the question, but not that little part of it. There's a reason why there's medical mistrust. It's because there's ongoing medical mistreatment. There's historical mistreatment, and that's very important, but this goes on today. And so these hesitancies that people have about some vaccines can be a reflection of what's going on currently to them and the people that they know. And so we have to balance that. A parent being hesitant about vaccination can reflect their general sort of apprehension about the medical setting that may not have anything to do with you individually as you're providing medical care or supporting medical care. But we do need to look to these community members with respect and with patience, knowing that they are uncomfortable, and we have to do everything we can to make it a safe environment and to build trust with them and to earn that trust.
Very important points. Okay, we've got one that says, I'm a director of a local public health agency, not a physician's office. How would you suggest we get 9-year-olds into our office? Currently, we are starting the HPV vaccine when we are giving them the Tdap and meningitis, because that is when we are seeing them in our office.
I think that's a really smart approach. The bundling approach is a really good approach. Getting them in earlier may or may not be within your ability to do. What if instead you worked with community partners and try to get them all on board to bringing people in earlier? 80% of HPV vaccine happens in a pediatric office. So it may be that you can have a bigger impact by moving your community forward in this area of age 9 through a consensus building process that involves partnering with local provider and nursing organizations. And then you can also do it in your clinic as well, but maybe a shift is possible, a shift in thinking. Getting folks in earlier is a little harder. Maybe there's another service you can offer that will be relevant as well. That's maybe not vaccination, but another service. It's nice to bundle things together because parents, we're all just a little bit busy these days. And that picks up on another question, another part of another question. Someone asked about in the context of the pandemic, HPV vaccination in the context of the pandemic. We had a big dip in HPV vaccine uptake that was related to a drop in well visits. So increasing well visits is the key. We're not fully dug out. We had a little bit of a dip in the overall national numbers, and some subgroups maybe even have a larger dip, but mostly we're back on track. But getting folks in for regular well visits is the key to getting high rates of HPV vaccine uptake. The well visits are the key for this.
Wonderful, thank you. Okay, I mean, we are still having questions. Melissa, do we have time for one more, or
I believe we have time for just one more.
Okay, so this one says, we have some hesitation from our school board about offering HPV in the schools because they say it's too controversial. Can you provide some guidance on how to overcome this obstacle?
Okay, so I've dealt with this before in a couple different ways. And it is true that some people have the impression that HPV vaccine is controversial, but surveys of parents regularly show that HPV vaccine is the vaccine they're especially interested in, along with the other vaccines, about as interested. What happens though is that providers of the vaccine often mistake that. They think that, yeah, the HPV vaccine is the problem vaccine or the one that everyone's worked up about. That's more of a media perception and a social media perception than a reality. Parents want cancer protection for their kids. So we need to make it as accessible as possible. And making vaccine accessible is an important equity issue. So if there is a concern about this, it may be that the concern is about a handful of parents, not about the broad range of parents. And I think it's always important to make sure that we think about populations of people and that we include the largest populations in providing services while also trying to address the needs of some of these smaller groups. So I would go ahead, but maybe have some educational efforts as well. And the key thing here, earlier age is helpful because it gets you away from conversations about sex, but also in your materials and as you're doing this, focus on cancer prevention, not on sexual transmission. This is not about sex. This is about preventing 6 cancers.
Great, thank you so much.
Thank you, everyone, for submitting those questions. And thank you, Dr. Brewer, Dr. Young, and Dr. Alexander, and the audience. I hope that you all feel a little more confident, a little more inspired and empowered to take back everything that you've learned from the AAT presentation and their team to reflect on what you can do in your respective organizations. And now I'd like to pass the mic to Christina Turpin from the HPV Vaccination Roundtable to share with you some of the incredible resources and materials available to you. Christina.
Yeah, thanks, Melissa, and thank you, Dr. Brewer and Dr. Young, and especially Dr. Brewer for setting up the National HPV Vaccination Roundtable so well. You can see some information here if you're unaware of the work we do. We're a very large coalition of over 80 member organizations across the nation that are all working like you to reduce the incidence and mortality from HPV-associated cancers. Next slide. And I'm going to be here to just tell you a few resources that can really accompany some of the information you've heard today. If you are traveling down that road of wanting more information, looking at different resources, we have a lot of different resources available on our website, on our YouTube channel that I'll talk about a little bit more, that you can utilize in trainings and educating yourself. If you get questions, you can use some of the different printable materials we have as well. So I'm going to go through a little bit more of that today. This first one here, we've talked a bit about starting vaccination at age 9, and we have a really great journal supplement out in HVI that you can see highlighted here. And there are, I don't even know how many, I think over 20 articles now within this collection that you can read. And there you can see at the bottom a little bit of the research, including different information there. We've also taken many of those articles and turned them into video abstracts. These can be great for a clinical education opportunity. They are shorter, usually like 3 to 5 minutes. You can watch them a little bit quicker, and it summarizes that author's work in the journal supplement. So these are a great resource when you're looking into that science base for starting HPV vaccination at age 9. Next slide. We have so many different resources for so many different things that you're working on. So you can see some of them highlighted here. We have a lot around why start vaccination at age 9. We have a landing page for that where you can find different resources for different audiences there. We also have evidence summaries. You see one of them highlighted here for rural disparities. We have our action guides, which are great for large health systems, small private practice, and we are currently updating those. We also have one, I saw someone posted a question about dental. We also have one available for our dental colleagues. So you can see that highlighted at the top right there, where you can find that on our website in the resource center. And we also highlight resources from other organizations. You can see the announcement approach flyer highlighted on this slide, which you can also find in our resource library. Next slide. We have a YouTube channel that houses that 9 for 9 video that Dr. Brewer just put into chat. So if you're thinking later, I have no idea where to find that, I did not save the link. If you visit, just search the HPV Roundtable, you'll find our YouTube channel. You'll be able to find that 9 for 9 video, as well as all the webinars that we produce as a roundtable are saved there for your viewing as well. And next slide. And I think that's it for me. So thank you for having me. If there's a resource you need, feel free to reach out to myself or any of my colleagues at the roundtable, and we are here to assist. Thank you.
Thanks, Tina. And we actually got a question in the chat for you.
Yeah.
We have some eager folks. They're asking when the health plan action guide will be released.
I feel like you should bring Katie back on here too, but I think we are hoping within the next couple months. We are in the final design stage, content is there. And so I think we want it like in 2 weeks, but I would say realistically, probably within the next couple months.
Yeah, definitely.
Excellent. Thank you. Thanks, Tina.
Yeah, thank you guys.
Well, it's crazy to think that the hour flew by, but we can't close out with also presenting you with some exciting opportunities. And if you missed all of the links in the chat, this will also be shared in the follow-up email. There's also an opportunity today, as you know, was the first best practice session. We have a remainder of 3 for 2024. And the structure for the following sessions will be health system partners presenting their HPV initiatives and best practices. So if you have not registered, please take the time to do so. And remember that we do have continuing education credits for all of these. Next slide. Last summer, we also, in partnership with the Roundtable and the Indiana Immunization Coalition, launched a 6-part on-demand provider education series, which equips providers with the latest information, guidelines, science, and implementation strategies to increase HPV vaccination rates. We also do offer continuing education for all of these, and you can view them at your leisure and in any order and any pace. So please share this incredible opportunity with your partners, and you can see a sneak peek of the sessions and the speakers. Next slide. We're also really excited this month to be launching a rural healthcare partner learning community where health systems will have the opportunity to learn from each other and subject matter experts on utilizing quality improvement and evidence-based interventions in their health systems to increase HPV vaccination. And I'm happy to say that our first session will be on March 20th. So if you're a rural healthcare partner, please register if you're interested. Next slide. Another resource we wanted to share is an overview of our evidence-based interventions. This resource includes 4 cancer screening types and HPV vaccination and highlights client-directed, provider-directed, and community access interventions. This document is continuously updated, so if you find it helpful, please do bookmark it so you have the latest version. Next slide. I'd also like to tease out our summer social series. This social media toolkit will have refreshed photos and messaging around HPV vaccination and back to school campaigns, and it will be available in English and Spanish. Next slide. And finally, please take a moment to provide us feedback. It helps us plan our future learning sessions and the content, and we want to cater to what you want. So please do click on the link in the chat or scan the QR code and give us your honest feedback. And finally, for our next steps, we'd love for you to complete the survey in the chat to claim your continuing education credits. So Katie just posted it in the chat. If you miss it, it will also be available in the follow-up email. The follow-up email will also contain all of the resources shared on today's call, along with some other additional resources and the recording. And finally, if you're interested and expressed interest in the poll, UNC will be emailing you their AAT training materials. Next slide. Finally, this work would not be possible without the support of our funders. We are so grateful for their ongoing partnership and support. Next slide. And as we come to a close of this informative and engaging meeting, I want to again express my gratitude for all of our speakers for sharing their time, expertise, and invaluable insights. I also want to thank each and every one of you for your active participation and insightful questions. It is through collaborations and knowledge sharing that we can make a meaningful impact against the fight of HPV-related cancers. Together, we can create a future where HPV-related diseases and cancers are a thing of the past. So thank you again for your time, and we really hope to see you in our May session. Thanks, everyone.